We're really excited to have this conversation around artificial intelligence in patient care. And when we talk about AI in patient care, as it's been said, it can sound abstract, it can feel a little intimidating, but at its core, the discussion we want to have today is not about algorithms per se, but it's really about time, access, clarity, and ultimately why we're here, patients. AI is already shaping how melanoma is detected, how clinical trials are being matched, how data is being interpreted, and then, yes, how care is being delivered. So the question really is no longer, is AI coming to patient care? The question for all of us in this discussion today and for the days ahead is how do we harness it responsibly, equitably, in ways that it will strengthen, not erode, the human center that is the bond of medicine. I'm really thrilled to be here with Dr. Veronica Rotemberg, who I think got the last train out of New York City to be with us today. So thank you for making that effort through the snow. And snow would not stop Keith Tolley, who would love to have been here with us in person, but he is joining us virtually. So I'm really excited to have both Dr. Rotemberg, whose research that we have been proud to invest in. She's been on the forefront, and she is a pioneer in terms of AI detection. And then Keith is always kind of a North Star voice for us in terms of the patient community. So welcome. So I want to open it up to the both of you, and we'll start with you, Dr. Rotemberg, first. But the question for the both of you is, when you hear AI in patient care, what excites you the most?
Gosh, I could answer that question for this whole time, but I'll try to keep it brief. Most of my research is on early detection of melanoma, and I think one of the things that's so cool about skin and dermatology is that it's so easy to take a picture, right? So there's so much opportunity to try and detect skin cancer, especially melanoma early. We've also found in some of our research that, many of you, we heard from someone earlier today, especially once you're in a high-risk category or you're in a high-risk category, all of a sudden, you might get 7, 8 biopsies every time you see a dermatologist. That's a very common story that I hear. And there's a lot of opportunity for AI to reduce unnecessary biopsies in addition to improving catching melanoma early. So I think that's maybe the lowest hanging fruit in terms of AI, but I think the newest models have kind of unlimited potential to change the way we deliver care, that we're just scratching the surface.
Great. Keith, over to you. As a patient, how does AI excite you? And then obviously we're gonna talk about a little bit of the flip side of that, but I'd love to get your perspective as a patient.
Sure, so hopefully you can hear me okay. On a practical level, I can get, and I'll say cautiously excited about what I'll call the assisting possibilities that this new technology and these large language models might enable over time. Possibilities like, helping researchers discover more highly accurate and precisely predictive biomarkers, as well as more innovative and effective and hopefully less harmful ways to defeat all forms of melanoma. Also, the possibility of assisting, as Dr. Rotemberg just highlighted, care providers to improve early detection and diagnostic methods to identify melanoma much earlier in its development life cycle for all melanoma patients, and the possibilities of helping to relieve, from what I understand, some of the extensive reporting and communication burdens that care providers now face, to give them, I hope, more time to spend with us as patients. And then finally, assisting us as patients and caregivers alongside of our care providers to match us to clinical trials, as well as to help us as we collectively seek to find the answers to the who and the what and the why and the how questions that confront us along the entire disease journey. Now, while I realize that we are certainly not anywhere near experiencing the fullness of these things yet with this emerging technology, I can get cautiously optimistic about the possibilities that might become reality in the near future with patients and for caregivers.
Thank you so much for that. As many people may be aware, 40% of the United States lives in what we call a dermatology desert. They don't have immediate access to a dermatologist, and if they do, that wait time to be seen by a dermatologist, unfortunately, could be 5 to 6 months. And in the case of melanoma, which all of you in this room certainly can appreciate, but not everybody maybe fully understands, unfortunately, melanoma is a very fast-moving cancer. So from your perspective, Dr. Rotemberg, how realistic is it in terms of AI's potential to expand access and potentially reduce those dermatology wait times, and what's some blind spots around that?
I think that's such a great point, and it's such an area of immediate need. I think that we can learn a little bit from other countries where they are really trying to develop systems for rapid access to dermatologists for highly suspicious lesions. We know that in the UK, they're piloting programs that use AI for photographs to try and fast-track patients with suspicious lesions. And I think programs like that are really promising. I think they also highlight for us, and this is why the MRA is so special, rigorously testing these programs is what we really need to know, because at the end of the day, if we launch those programs and they actually flood the dermatologists and increase the wait times because the algorithms don't work that well, then we've actually done the opposite of what we really need to be doing. And that's really the challenge of translating these algorithms that seem so wonderful on paper to the real world, where we really need to test them and understand, are they having a benefit? I think access is one of the areas where we can really do that kind of experimentation, but we really need to know the answer, because 10% of a challenge in specificity, so a false positive rate, may just completely tank the performance and make the situation worse. And we obviously don't want to do that for our patients living anywhere in the country, especially that have limited access.
Absolutely. And I think one of the other challenges that we certainly have been working on from a Melanoma Research Alliance community is most of the algorithms have been trained to look at skin that looks like ours and not really truly reflective of the beautiful complexion that does make up patients all around the world, and certainly for patients of color. We've invested in those areas to create open data sets so that that algorithm can look at that skin color more accurately than just where the AI algorithm's been trained, on top of which even things like tattoos can kind of mask some of that. How are you seeing some of those AI blind spots in terms of data set biases, rare subtype representation, digital access gaps? How are you seeing that within your practice?
That's such a good point, and such an amazing area of focus. We know, maybe 5-6 years ago, algorithm performance was shown to completely tank in anything that we call as researchers, outside of the distribution in which it's trained. So that will include, most data sets for melanoma detection are developed in cutaneous melanoma, they're developed in fair-skinned individuals, and they're developed in high-risk clinics. But actually, most melanomas in the country are diagnosed outside of high-risk clinics, even if high-risk clinics might have a higher percentage of visits that diagnose skin cancers. And so, that's just a very limited population. And in the last 5 years, we've seen so much work to diversify our data sets, to change those distributions so that these algorithms will work for more people. But we still have a lot of work to do. And we know that little things like lighting conditions, camera type, even things that we would totally take for granted, you upgrade your phone and you're not thinking, all of a sudden I have a new flash, I have a new this, I have a new that, but it might affect the algorithm performance. And so that's one of the reasons where I think the data sets and benchmarks are going to be so key to understanding how the algorithms will work. And when we think about trying to deploy them in the general population, which is the ultimate goal, is to have access to algorithms that work for everyone, we're going to need to be really, really careful about understanding how they work.
One piece of our discussion that we had prior to us coming together today is this idea that technology moves fast, but trust can move slow. And so, Keith, over to you. Like to talk to you, have you share your perspective on trust within the AI-assisted space that we all now live in. And just if I look out into the room, how many people here, if you can raise your hand, have used an AI chatbot, ChatGPT, Claude, something along those lines, to kind of take a look at your medical records, to help structure questions? Raise your hand if you're using AI in some way to try to assist your navigation. Okay, majority of this room, which is, I think, a really good thing for us to explore. So, Keith, from your perspective, I'd love to talk to you about where are your trust levels in terms of AI-assisted tools and helping you better understand, and what are some of the areas that give you pause around this?
Yeah, so I think the question is, would I trust AI-assisted large language models right now for some of the tasks that I want to use as a patient? And my simple answer, to that is a qualified yes and no. As was pointed out earlier, these AI-assisted tools are being used by dermatologists to help them screen for and identify melanoma, and that's really have been helpful. And also, as I understand it, radiologists and pathologists are already using AI-assisted tools to help them analyze things like patient imaging and tissue sample results, and they're using that for diagnostic purposes, which are then translating into, treatment decision-making conversations. So in that sense, that's my qualified yes. I would trust the use of these kinds of AI-assisted technologies if they're in the hands of an AI-competent and experienced care provider or technician. I would not, however, fully trust current AI-assisted large language models all by themselves to accurately provide us with the most up-to-date, complete menu of possible treatment options for our unique situation. And I have firsthand experience and evidence to support my caution. So no, I wouldn't trust them right now to provide the most accurate, unbiased information for us, though they can be helpful. I would also suggest that I would not trust the use of these tools in the hands of a care provider or technician or someone who lacks the training and the experience and the wisdom to actually be able to use these tools accurately and effectively for things like treatment decision-making for patients like me.
Thank you. Dr. Rotemberg?
Keith, I think what you said is so interesting. You did such an amazing way of describing the different AI-related healthcare tools that are out there. There's this bucket of tools that I would call, like deep learning tools that have undergone a regulatory process. So, the ones that you're talking about in terms of radiology, pathology, et cetera, the FDA has said, they're approved for classification, and a hospital or wherever you're seeking your care has evaluated their publicly available data and has said, we think this is going to work well in our system. That is a broad category of things. The other categories that I think you are right to express caution about are the ones where we don't really have that process and we don't know how well they work. So when you start, interacting with off-the-shelf chatbots about your healthcare, I can completely see where it can be helpful, it can provide context, it can help prepare for a visit to a provider, and we have no studies that tell us, how accurate are they? How helpful are they? How do they benefit patients? What are the long-term outcomes of these types of interactions? And I would say, my experience on the other side with apps that are available in the App Store, and I already warned everyone that I was going to talk about this, so sorry,
Yeah.
is that, those have not undergone mostly any studies at all. And I often receive a screenshot of a photo plus the AI, perspective. A patient will send me a MyChart message that will say, I have this spot and this is what, the app that I downloaded says. And it's, the performance is very variable. The latest studies that we've seen suggest, 20% accuracy for melanoma detection. I mean, horrible. And we don't have regulatory oversight in those right now. And so there's just so many different categories of places where AI can be involved in your care, and so many different levels of evidence that is required right now, that I feel like it's the Wild West. I thought your framework was so good, Keith, for thinking about the different places.
So as patients are looking to some way make sense out of very complicated information, right? And so often patients get their MyChart results, and we talked a little bit about this at last year's forum. They get their MyChart results in before they've had a conversation with their healthcare provider. And I think it's very human nature to say, what does this all mean? And then you want to upload it into a ChatGPT as an example, and hopefully help you navigate that. From your perspective, when patients may come in with all of that, what's really helpful in that conversation in terms of, it could be helpful to have maybe some structured questions to be able to ask, and ChatGPT or Claude or any of these AI-assisted spaces can maybe help a patient kind of gather their thoughts together. So what's helpful and maybe what's not so helpful in those concepts when you see it in office?
I always say, every patient is different. I raised my hand too because I'm a dermatologist. I have this specific expertise. I have all sorts of healthcare outside of my domain of expertise. And I know for myself that I like having the information from the LLMs, and that I can use that information with caution, because we don't really know how accurate it is, how relevant it is to your personal situation, and what your doctor is going to say as a result of these information. But every single one of you is going to be different too. I would never tell someone to not access information that might be available to them. But if you find that it's not helping you, that it's adding more stress, that it's creating a challenging situation when you go see your doctor, those are the types of critical evaluations that we all have to make when we are thinking about our own health care. But there's no blanket statement to say yes or no, these tools are good or bad. They're just a tool that's flawed, that is available, that all of us have to decide when and where they're helping us.
No, I think that's great. I mean, I think it's this idea of, can it help prepare the question so a patient can have in front of them and it doesn't just feel like off the cuff, and they may be able to go in and feel a little bit more prepared for a deeper, thoughtful conversation. I think it's also maybe a great way to organize your medications, side effects, so you can improve those conversations with your care provider. It could also be helpful in drafting insurance appeal letters, and I've heard great success, from that perspective. But Keith, I'm curious, and you are always so wonderful to give your wisdom and your time to so many other patients. We see in the news all the time, AI is going to replace everything, which I do not believe to be true, but that seems to be right now kind of the bingo game that we can hear about. From your perspective, have you heard anything from the patient communities and the patients that you partner with? Is there a worry out there that AI being used in ways that might limit patient care?
That's a good question. Even though, AI is receiving a lot of press and interest right now, my sense is that up to this point, there's not a significant percentage of melanoma patients who have been worried about AI placing limits on our care. So I just don't think it's out there yet. But that might all change, and it might all change kind of rapidly if the spread and reach of this technology continues at the pace it has been, and as we all gain a better understanding of what this technology is capable of now and what we're hearing it might be capable of in the near future. So in terms of the narrow part of your question, limiting care, I don't really hear that. And Dr. Rotemberg might be hearing that, but I don't hear that a lot from patients right now.
Not right now. That might be partially because we are wearing rose-colored glasses too, where we can see the potential of this technology to benefit so much more, and we're focusing so much on exploring those. But I agree with Keith. I'm not seeing that side of it yet.
I think one of the things I personally see with my own healthcare providers is they'll say, hey, we happen to have an AI-assisted scribe. And what I've noticed is that my healthcare providers now can be really focused on the conversation with me versus having to type and, kind of multitask in that moment. And so I think that's a small way that AI can help improve that relationship and that one-on-one that I know so many healthcare providers want to have. Another thing that we talked about is just even efficiency, and I think in our previous conversations is this idea of how can we maximize, treatment spaces for whether it's chemotherapy chairs, the ability to become more efficient around surgery so we can take every available spot to create patient efficiency. And I think those are going to be small and yet big wins for the patient community. And are you seeing that currently at Memorial Sloan Kettering?
Totally. I think those auxiliary AI tools that are around diagnosis are absolutely exploding, and I hope that we start seeing more evidence that they help. I think chemotherapy scheduling is one of the examples. There's multiple off-the-shelf tools that exist already. Radiology scheduling, trying to really get the CAT scanner on every single minute of every day so that patients don't have to wait for their scans. And I think there's going to be a lot of potential to improve healthcare based on tools like that. Even a small thing, now you can use these kinds of tools to add, when you have to take certain medicines to your calendar automatically, and little things like that where I think AI agents are going to start really making patients' lives better in ways that we can only really start to imagine now.
I want to make sure we have enough time for questions. So for both of you, 5 years from now, which I know right now it feels like we can't even think out 6 months, but 5 years from now-ish, what will feel hopefully routine when what today feels like cutting edge, but hopefully will feel a little routine? I don't know if you can think about that from a futurist lens, but maybe your hope there.
You want to go first, Keith?
Keith?
Sure, I'll jump in. Well, let me just say 5 years, that's a long time, right?
Yeah. Or a year from now.
Yeah, well, it could be. I will say from a disease perspective, I hope that we routinely hear that every year going forward, there is 0 deaths from melanoma. And from a technology perspective, other than helping to discover a large group of new, highly accurate and precise predictive biomarkers that will point patients to the most highly effective and minimally harmful treatment options for their unique disease situation. I think there's a couple of things that might happen, in that 5-year horizon that, as Dr. Rotemberg just mentioned, we may not even be aware of, but I can see these things happening. So I'll just jump in them real quick, and then 2 of them came to my mind. One is I could really see, I wouldn't be surprised if in a few years, something like an AI digital agent or assistant is working alongside of researchers and clinicians and administrative personnel handling many of the research activities, much of the data gathering and synthesizing and reporting activities, and many of the project management, communication, administrative activities that right now are currently being used or handled by a human resource. I also wouldn't be surprised if in a few years melanoma patients like me are actually assigned something like an AI digital agent or assistant by the clinic or the center or the hospital where we're receiving our care. And this agent, in whatever shape or form that looks, is going to assist us and our caregivers in navigating and completing many of the administrative and the logistic and the communication activities and requirements that we're going to face, as well as addressing many of the non-emergency related questions and concerns that we might have. I think these things are definitely a possibility.
Thank you for that. What about you, Dr. Rotemberg?
I totally agree. I always say, any AI talk gets kind of like metaphysical, kind of right away because we don't know. And what I think our job is, and Keith, I really liked your vision for it, is to think about, what do we want our relationship with our doctors, our relationship with our healthcare team, our care to look like in 5 years? I think the idea of an AI agent is a great one. There's all these questions that come up over the course of your care, and there's like 17 different people that you have to contact to get answers for each one. That's such a good example. And I think this is such an opportunity to say, what do we want care to look like in 5 years? I would like patients to be able to know the answer to their questions in a reasonable amount of time. I would love them to know when I have asked them a question in a reasonable amount of time. I'd love them to get care at home when they can and have to come in as little as possible. I want to start from first principles, but I don't want to do it by myself. I think we have to come up with it all together. And the technology is going to be there, I think, to enable, a transformation of what this looks like, I think, for the better.
Great. I want to open it up to some questions. We've got Renee Orsioni in the back with some microphones, and why don't we go up front right here?
My name is Clay Hummer. I'm a survivor. I've been doing this for, I guess, 10 years now. And you all kind of touched on what my question is. I got to thinking about Ms. Gill's migrant farm workers. My doctor, oh geez. My doctor participated in a paper back in 23 that looked at if I were paying ChatGPT the $20 a month, I was getting more accurate answers as opposed to the ones that you find on the app store that's built by me in my mother's basement sort of thing. And I guess the question that I have is, given how we have swaths of this countryside that don't even have are still working off of dial-up, are we not creating yet another layer of haves and have-nots in the medical community that these AI are going to be responsible to?
That's such a deep question, and the short answer to your question is yes. And the haves and have-nots are defined in so many different ways. It might even just be like you and your doctor have the camera that was used to train the AI model, so you're more likely to have an accurate response than a doctor that is using a different camera. And I think the question and the reason that this is such a wonderful forum is, how do we make sure that doesn't happen? What kind of experiments do we need to do? What kind of community do we have to build so that we're not making the current inequities in healthcare worse? And I think we have a lot of ideas about how to do that. The first is to, test the tools where they're designed to be used to make sure that there's not gaps in our training, and lots of other things that we have to do too. But it's a great, great question, very important.
Thank you for that.
We have
Do you
another
other
question.
questions?
Yes.
Dana? Okay.
I was just curious, how do you feel like it's affected you as a doctor and your patient connections? Is it like worse or better? And do you feel like you've had to really dive into your own AI knowledge as a doctor?
I want to hear your thoughts too, Keith, from your perspective. I think it's very different for me because I'm an AI researcher. So I talk about this all the time. It's not, I sort of lean into these kind of conversations with the patients, but we definitely are a long way from every doctor in the country being able to have a conversation about AI with their patients. And with the current environment, especially around LLMs, each individual doctor has to do their own research a little bit to figure out which LLMs might work for their patients. And that's an impossible task. So we're a long way from figuring this out. But I think we'll see how it goes in terms of the conversation with patients. I think your example about the AI scribes is a great one. Anything that gets us facing the patient and not the computer is a win. And that's in so many ways. Anything that handles my scheduling, so I'm spending more time with patients and more time on the in-basket is also a win. So I think there's a lot of potential to improve the patient relationship, but we have to be careful.
Great, thank you for that question.
Hey there, thank you so much for this. This is really fascinating. So talking back to the dermatology desert, I think that's a really huge issue for us for prevention and access to care. Do you use specifically anything at MSK to help you with with getting these people in earlier?
There's a couple questions that are related to access, and all of them are really important, and we're studying them at MSK, and then there's also great researchers studying them all over the world. One of them is, can we diagnose melanoma remotely? What tools do patients need in their house for a melanoma to be able to be diagnosed? I think that in some ways is the holy grail. It's challenging. For most AI algorithms with high performance use a dermatoscope. And so there are studies in Australia and other parts of the world where they are mailing dermatoscopes to patients, and they're saying, can you take photos with this dermatoscope and we'll try to diagnose this melanoma remotely. There's educational initiatives, just like we heard about earlier today, that help patients try to understand which of your spots is most likely to be a melanoma, because that's also a challenge. If you send me a photo, but you have a melanoma somewhere else on your body, I will never know. And that's really scary for doctors right now. And so there's other work that I think is also really excellent in trying to understand underlying risk. So how do we remotely assess patient risk? And there's projects in Australia, again, using total body photography to try and say, these patients have more than 100 moles, these patients have this genetic susceptibility, these patients are at high risk, let's get them in sooner. But we're still waiting for a lot of data to come out from these studies to understand how well they actually work to catching these melanomas early, which is what we're trying to do. But it's a great question, an open question for us.
Yeah, and MRA has actually been investing for nearly 10 years in this. AI is just the really lovely term for large language models and big data sets, and feels very kind of cool and future thinking. We've been actually investing in some research around this idea of piloting at your local CVS Minute Clinic, where a patient could immediately kind of go in with someone who's been trained, be able to take that photo with the right type of equipment, and then it would be transmitted to world-class pathology. So it could be in New York City, it could be in Estero, Florida, to immediately say, let's triage that. We think that that's fine. That's another type of dermatological condition. That's not skin cancer or melanoma. this needs some active surveillance, or we now need to figure out a way to quickly get that patient into a dermatologist. And that's some of the pilot work, thanks to those who support MRA, that we're piloting, but it's going to take a moment because there's huge, we could be here all into next week talking about various levels of access to care, and it's literally zip code by zip code. You know, we talk about in New York City, or any major, urban setting, you probably may have access to a lot of dermatologists. And so we talk about in New York City, like the Upper East Side, there's probably, a dermatologist on almost every corner on the Upper East Side. However, if you get down into the far Rockaway there, and into the Bronx or parts of Brooklyn, there may be one dermatologist for 600,000 residents. So it really does become zip code to zip code in terms of those opportunities. Keith, I don't know if you wanted to add into that in terms of what your perspectives are in terms of that care between you and your healthcare provider now that AI is really infusing itself.
Yeah, I think that, and I loved what how Dr. Rotenberg kind of positioned all of it. We want high tech, right? We want it to be as accurate and robust as possible and save time and all that, but not at the expense of personal touch, right? I mean, there's nothing like having that personal touch with a care provider who has empathy, has intuition, understands my disease and life context. AI doesn't have that. These large language models, they don't provide that for me. They provide answers and they kind of wrestle together with me depending on how I prompt them. So, talking about screening and, early on in the journey, and trying to be preventative, I can definitely see how some of these tools would be wonderful to have, whether they're remote or not. When you move beyond that, though, and now you're a stage 3 or stage 4 patient, right? You're really looking for, because there's fear and all of that. I don't want to replace the human touch that could be available, but I'd love to have better, more accurate, more robust technology to come alongside of me into that setting and in those conversations.
That's great. Well, do we have one? I mean, one
We
last
do have
question.
one more.
Okay.
Hi, everybody. My name is Javier Velez Martinez from Puerto Rico. And, I have a kind of unique perspective because I was a patient myself of melanoma, but also, currently finishing medical school and wish to pursue a residency in primary care. So my question to the doctor will be, are there currently any initiatives in the dermatology community to provide some sort of training for primary care physicians, maybe assisted by AI, to, that gap between the patient and the dermatology visits, could be any shorter?
That's an amazing question, and the answer is yes. And there's so many things, and I'm not even going to be able to create an exhaustive list. But I would say there's a couple of buckets of things. First of all, there's incredible educators working on disseminating dermoscopy and diagnostic education to primary care providers. So little things like just adding a dermatoscope, so that's the 10x polarized magnified lens that dermatologists use to improve our sensitivity and specificity for melanoma, adding dermoscopy education to the primary care curriculum so that primary care doctors are confident in their ability to use that technology, having telehealth referrals, so easy access to a dermatologist when you do see a suspicious lesion, because even if you find one, we need to actually make sure that that person gets where they need to get. There are emerging AI tools that are intended for primary care. Oh gosh, I'm so sorry, guys. Primary care providers. I would say, as I said sort of earlier in the talk, and everything comes full circle, we need to test them in their intended use setting. Primary care is a perfect example. If we improve primary care diagnostic accuracy for melanoma by 10%, doesn't seem like that much, we could transform the lives of patients. But we need to make sure that we're not flooding the dermatology referral pathway and that we're not missing too many skin cancers by doing that. And we can only understand that by testing them in their intended use setting. One thing that I often think about AI trials, though, is, an AI algorithm, it's like a little beep, right? Mm-hmm. And so we often think about clinical trials in the context of therapy. And we think about them as long, and we think about them as really expensive. And one of my goals is for AI trials to not feel that way, because we can test them fast, and we should be able to test them fast because they're going to change in 6 months. So I think the answer to your question is yes, but we have a long way to go, both in the tools and also in how we test and assess the tools to know that they're working. But my hope is that we'll get there.
Great. Thank you so much for that. And as we wrap up, I think we come back to that simple truth that technology moves fast, trust moves slow, and I think if we're going to continue to innovate within melanoma care, we also have to start moving at that speed of trust. We're getting there. I mean, I think we've had a kind of a robust conversation of where we need to close in on some of those gaps and disparities. But ultimately, behind every algorithm is a human decision process. What's next? How am I thinking about this? What does my primary care physician, my healthcare team say? And so AI is not going to replace our doctors, our researchers, our clinicians, the patient voice, but hopefully it's going to help us move to speed faster with trust so we all can have a different conversation a year from now, 5 years from now. Dr. Rotemberg, always a pleasure to spend time with you. We're so honored and proud to be supporting the incredible work that you and the team science is doing across Memorial Sloan Kettering, but as in fact, informing the rest of this continuing AI. Keith Tolley, you're incredible. We are so appreciative for all that you do for the melanoma community and your voice. And I would be on these conversation panels with you every day and twice on Sunday, and I appreciate your time. Thank you so much, and we're going to hand it over to the next panel. Everybody, please enjoy the rest of your afternoon. And up next, I think we have Dana Dayton.
Thanks so much.